All right, welcome to another session on topics related to nerve surgery as part of an educational initiative through the Joint Section on Spine and Peripheral Nerves. My name is Jared Pisapia. I'm a neurosurgeon at Westchester Medical Center, and I'm joined by my co-host, Elias Rizk, a neurosurgeon at the
Yes.
University of Texas at Austin. We're very pleased to welcome Dr. Eric Zager. Eric Zager is a professor of neurosurgery at the University of Pennsylvania and also my mentor. So thank you so much for joining us today.
My pleasure. Thank you for the kind invitation.
All
Thank you for
right,
joining us.
so last episode we focused on carpal tunnel syndrome, and we'd like now to cover the second most common peripheral nerve entrapment, which is cubital tunnel syndrome. So, Dr. Zager, when you refer to a patient in the office for cubital tunnel syndrome or ulnar neuropathy, what elements from the history are you looking for to make the diagnosis?
Sure. Well, unlike carpal tunnel, ulnar entrapment neuropathy at the elbow can often present more with motor symptoms and findings rather than sensory findings. With carpal tunnel, patients almost always tell you their hands are numb, tingly, painful, wake them up at night. With ulnar neuropathy, often the patients develop slowly progressive weakness and atrophy of intrinsic hand muscles and find that they're dropping things. They may say that there's also numbness in the ulnar aspect of the hand and the fourth and fifth fingers, but often that's not a prominent part of their presentation. And the classic presentation will include some pain at the medial elbow, tenderness overlying the what people call their funny bone. There may have been prior trauma to that area. People are constantly bumping their ulnar nerve and getting a little electric shock down the arm into the hand. But very often the prominent feature is the weakness and atrophy. This often presents in a somewhat advanced state rather than the early presentation with sensory symptoms as seen in carpal tunnel syndrome. So I'll ask them about their handedness, about their occupational activities, their recreational activities, whether they tend to drive with their elbow on the windowsill, whether they sleep with their elbows hyperflexed, which puts the nerve on stretch. And also an important feature is whether they've had serious trauma to the elbow, even years or decades before. The way this ulnar entrapment neuropathy was first described in the 1870s was what's called tardy ulnar palsy or ulnar neuritis. And the classic history was a severe elbow trauma, fracture or dislocation of the elbow, followed many years later by progressive weakness and numbness in the ulnar nerve distribution. And that may be due to callus formation from the fracture or scar formation from the significant trauma. That's not a very common presentation these days, but that was the original description.
I also see it sometimes with avid bicyclists, especially at the compression at the wrist that come up, or musicians. I had a guitarist once come in with Guillaume's canal. How do you tease out distal ulnar nerve compression versus proximal nerve compression?
That's an important differential. Of course, both of those can present with weakness and atrophy in the ulnar intrinsic muscles. So that includes the first dorsal interosseous, the abductor digiti minimi, the lumbricals. One of the important sensory differences is that the Guillaume's canal presentation will usually have sparing of sensation in the dorsum of the hand, as shown in the diagram here, because the dorsal cutaneous branch of the ulnar nerve arises proximally in the forearm. And so that is spared in the Guillaume's canal compression. Guillaume's canal neuropathy is much less common than ulnar entrapment neuropathy at the elbow or cubital tunnel syndrome, but it's an important part of the differential diagnosis.
We see on our neck of the wood with Jared possibly with spina bifida populations on the wheelchairs. We tend to see that early on in their. They can adjust the wheelchairs for these patients and try to prevent need for surgery.
Yes, I've also seen ganglion cysts in the Guillaume's canal that can be a mass lesion. So for the unusual entrapments, actually for both Guillaume's canal and even for the more common ones like ulnar entrapment at the elbow, I will get some imaging studies on those patients because you don't want to miss a mass lesion or some unusual cause of compression. You don't like surprises at the time of surgery.
And speaking of imaging, would you be able to take us through some of the studies that you would consider getting in working up someone with cubital tunnel syndrome?
Sure. Most of these patients already arrive in our clinic with an EMG and nerve conduction study. What you're showing here is ultrasound, which has really become very popular now. And I actually get an ultrasound study of every ulnar nerve entrapment neuropathy now because it's important not only to show that the nerve has compression, and often what's shown here is a dilation either just proximal to the postcondylar groove or within the cubital tunnel, and then a more normal nerve distally and proximally. But also, it's important to get dynamic views with flexion and extension of the elbow to look for subluxation or frank dislocation of the nerve out of the postcondylar groove. In my practice, I'm using a simple in situ decompression for most ulnar neuropathies at the elbow because there are now very good randomized controlled trials that have shown that that does equally well as the transposition procedures, and it's much simpler and safer to do, less complex. But for the patients who frankly dislocate their ulnar nerves with flexion, I will recommend a submuscular transposition. There are two other types of transposition procedures that are done commonly. The subcutaneous is probably the most common, and there's also an intramuscular transposition, which I don't really recommend because I think that causes more scarring by putting the nerve within the muscle tissue itself. I was trained by Dr. David Klein at LSU, who's really the granddaddy of peripheral nerve surgery in North America, in my view. And he always did the submuscular transposition and showed in hundreds of cases that he could get significant improvement. It is a more complex, involved procedure and generally requires general anesthesia. So I still now recommend the in situ decompression for most patients if they're not subluxing or if they don't have a distorted anatomy at the elbow due to prior trauma. Or if they have failed a prior simple in situ decompression, that's another indication for a submuscular transposition in my practice.
We have some images to show about some of the topics that we covered here. This is a video using ultrasound showing subluxation of the ulnar nerve over the medial epicondyle. So here you can see the nerve here, and as it reflects in the elbow, you see it pop right over that, out of that groove there.
Show that again, please,
sure, we'll go,
Jared, just so people can see it. It's a little hard to see if you don't. There's the nerve prior to flexion, and then during flexion, it goes over. This is the epicondyle here. It moves.
So I'll take it in slow motion here. It's kind of just reaching the apex there. You can see very impressive compression here.
Yeah.
And dislocates over. And again, this is the medial epicondyle, and the nerve is hypoechoic structure here.
Right.
This is actually a case of yours, Dr. Zager, that we did together several years ago, showing this intraoperatively. This is the right elbow, and distal is towards this direction. You can see the nerve here. I'll try to take it slowly here as we flex. There it is again.
Yeah.
And that's a key maneuver to do in surgery to make sure it doesn't, bounce out and in with the flexion and extension. So prepping the whole arm, to me at least, is essential to see what happens when you flex and extend.
And I'm curious, at the start of the case, do you usually start with sedation and then convert to general anesthesia if you move to a transposition, or do you usually do many of these cases under general?
Well, in the in situ decompression cases, I evaluate whether the patient will tolerate simple sedation and local anesthesia. In elderly patients, they often can't cooperate. First of all, putting the arm in a fully abducted position and externally rotated can be quite uncomfortable for an older patient with some shoulder stiffness and arthritis. So I may require a short general anesthesia for those patients. But in younger, healthier patients with a flexible shoulder, I'll do a simple sedation and local anesthesia. And I do look for subluxation, but quite honestly, I've made my decision to do an in situ based on their preoperative exam and based on their preoperative ultrasound. So I don't convert to a general anesthesia unless a patient really can't tolerate sedation. But I will not generally change to a transposition at the time of initial surgery. I'll do the in situ, and if there is a little bit of subluxation, most patients don't require a subsequent transposition, at least in my experience. I know many surgeons do convert to general anesthesia. I see no problem with that, but that's just not been my practice.
I agree with you 100%.
Yeah, definitely is a more involved procedure, but we do have some diagrams we could take a look if you'd like to walk us through just the steps of a simple in situ decompression and then also transposition.
Sure. Well, I think your first slide prior to this showed the in situ. There we go.
Yes.
So this is again on the right side, and proximal is to the right and distal is to the left. And the incision is a short incision. This can really be just in the range of 3 to 5 centimeters in length. And since the skin is quite mobile here, you get a retractor under the skin edge, and you can really decompress for 6 to 8 centimeters in length with a fairly short incision. And with the simple in situ decompression, you're not really trying to fully neuralize 360 degrees around the nerve, because that will actually increase the chance that it will sublux or dislocate. So it's really just unroofing the nerve by dividing the fascia that runs from the distal arm into the proximal forearm. And that goes by various names, which is somewhat confusing. Osborne's name has been attached as either calling it Osborne's band or Osborne's ligament or Osborne's fascia, and different texts will have it confused. So I prefer actually the anatomic terms of the arcuate ligament or the humero-ulnar arcade, which is basically the fascia that runs between the medial epicondyle and the olecranon. The nerve, the ulnar nerve, is closer to the medial epicondyle, so I bias my incision slightly toward the epicondyle. Some people like an incision anterior to the epicondyle, but I think you have more of a chance of injuring the sensory nerve here, the medial antebrachial cutaneous. So I keep my incision directly over the ulnar nerve. And people do talk about compression at the arcade of Struthers, which is shown in these diagrams on the right. I think that's a very unusual site of entrapment. I do feel with my small finger up proximal to the epicondyle to see if there's any entrapment there, but I rarely, if ever, find it. I think our experience and Dr. Klein's huge experience has shown that most of these patients are entrapped in the postcondylar groove in this segment right between the epicondyle and the olecranon. And you do have to extend your decompression into the proximal forearm. There is a fascial band that runs between the two heads of the flexor carpi ulnaris that has been called, again, Osborne's ligament or arcuate ligament or Osborne's fascia, and you must unroof the nerve for at least several centimeters into the proximal forearm to be sure that it's not compressed distally. And that really is a quick procedure. It can be done in 20 or 30 minutes, and it's all done as an outpatient, of course.
I'm sure you find the nerve more proximally because it branches distally. So that's, also a pearl for the young people, just to look for the nerve more proximal rather than distal so they don't get into trouble.
Yes, I agree with that.
Great. And of course, transposition a little bit more involved, a larger incision, but we could go over some of the steps here.
Sure. This has to be a larger incision because you don't want to kink the nerve at the proximal and distal ends. That's a major risk of this procedure. And as Jared said, it's got many more steps. You start with a decompression, the same way as you do the in situ, but over a longer segment. And then one of the first things I do, so I don't forget, and that is to look and feel for the medial intermuscular septum, because it's not typically a site of primary entrapment, but if you do any type of transposition, the nerve can then be strung over this sharp edge of the medial intermuscular septum that inserts on the medial epicondyle. And it's a sharp band of fascia that really must be not only divided, but as shown here, a segment of the septum is best resected. And you feel with your finger that there's no more sharp edge there, just proximal to the epicondyle, so that the nerve has a soft bed in its new transposed position. So that's the first thing I'll do after the simple decompression. Then we'll do a release procedure, which involves dividing fascia more anteriorly or laterally over the common flexor pronator group. And that will allow the muscular repair or the tendon repair to be done under less tension. So you don't create a new tight tunnel in the transposed position of the ulnar nerve. So that's called the release portion of the procedure. And you have to be careful because when you're doing that release, you have to visualize quite carefully because you're very close to the median nerve and the brachial artery. And you obviously don't want to injure those structures in the process of doing your fascial release. Then we do a Z-plasty or a step cut in which we cut the proximal portion of the common tendon close to the epicondyle, then do this step cut more laterally and anteriorly, and then the distal portion of that step cut is farther from the medial epicondyle so that you actually lengthen the common tendon by doing a Z-plasty repair. I learned this from plastic surgeons who do Z-plasties in many locations in the body to provide more space when they do a repair. And then you transpose the nerve, put it into the submuscular bed, and you want to make sure to go through the entire common tendon. You don't want to go too deep because you can disrupt the elbow capsule and disrupt the joint itself, but you want to see the intermuscular plane. The next plane you'll come to is the brachialis fascia. You want to leave that intact and put the nerve in the nice smooth plane between the muscles of the common tendon and the brachialis distally. So you make sure that the nerve is not kinked proximally or especially distally. You have to release this common tendon far enough distally so you don't create a new site of entrapment distally. And then the third panel in C, you do the interrupted nerve muscle repair rather with interrupted sutures, and make sure that you can fit your finger underneath that new submuscular tunnel so that there's plenty of room for that transposed ulnar nerve. And then the closure is fairly straightforward. So there are multiple steps to remember, and it's much more complex than doing a simple in situ decompression. That puts the nerve in a nice, deep, protected position. I find that to be the sort of the classic original Learmonth procedure, it was called many years ago when it was first described.
I think a lot of mistakes are the short incision that you talked about, and I've seen short segment, and the nerve is at an acute angle up and down, and the patients are absolutely miserable. So really pay attention to the pearls that you're discussing here. Thank you for sharing your experience. I know you glanced over it a little bit on the beginning. You probably have it down to a science as far as physical exam and EMG. What are you looking for on the physical exam portion or the EMG component?
Sure. Well, on the physical exam, yeah, I'm sorry we skipped over that, but it's very important to feel the nerve at the elbow. In most patients, you can feel the nerve. In very obese patients or very muscular patients, you may not be able to. But I tap over the postcondylar groove to see if there's a Tinel sign. I'll also tap more proximally in the unusual case of a Struthers arcade, and more distally to see if there's a Tinel's, because that is a good sign that you're dealing with ulnar entrapment at that point. You're looking for atrophy of the ulnar intrinsics, particularly the first dorsal interosseous between the thumb and index, and the ADM, the hypothenar eminence. You're looking to see if there's, in advanced cases, if there's a ulnar claw deformity where the patient cannot straighten the interphalangeal joints in the fourth and fifth digits because of weakness of the lumbricals. And you can test for Froment's sign, which I think everyone probably remembers from board exams, that you can't hold an index card in between the thumb and index because the adductor of the thumb is weak, and so they cheat by flexing the interphalangeal joint of the thumb, which is median nerve innervated, flexor pollicis longus muscle, rather than the adductor, which is ulnar innervated. And again, in advanced cases, you'll see a Wartenberg sign where the patient can't adduct the pinky finger, and so they get their finger stuck when they're putting their hand in the pocket. The pinky gets stuck because of the Wartenberg sign. So those are the basic motor deficits. And then the sensory deficit is the classic splitting of the ring finger plus all of the pinky finger, and the ulnar aspect of the hand has sensory loss. The farther distally you get in the nervous system, the more precise the sensory loss tends to be. You don't always see splitting of the ring finger, but that's the classic finding with ulnar entrapment neuropathy.
Excellent. And we have here just a few. Sorry, go ahead.
No, I was going to get onto the electrodiagnostic studies. Really, for nerve conduction, there are a lot of numbers listed, but I try to keep it simple. I look for conduction slowing across the elbow segment, and as shown here, there's significant slowing above when recording above and below the elbow. And then for the electromyogram, for needling procedures, we'll look for signs of denervation in the ulnar innervated muscles, usually the first dorsal interosseous and also the abductor digiti minimi are needled, and you'll see fibrillations and positive sharp waves as signs of denervation in the hand intrinsics. So those confirm your physical exam findings. If you don't have weakness, atrophy, or EMG findings, then it's a milder case with just sensory symptoms. You can manage that patient conservatively initially with recommending protection of the ulnar nerve with a protective sleeve, avoiding hyperflexion, avoiding repetitive trauma to the nerve, and you can try non-steroidal anti-inflammatories for symptomatic relief. And many patients can get by without surgery with conservative management. But once they have weakness, atrophy, EMG findings, then I think they are best recommended to have surgical decompression.
Does acute denervation, like fibrillation potentials, change your timing of surgery? Like on the fibrillation in the second column here, if you see somebody with 2+ fibrillations, is this more of, oh, let's do something surgical to save more muscle loss, or would you wait?
Yeah, that's a good question. I think it depends really on their exam and their and the degree, the severity of their symptoms. If they have uh, pronounced weakness, atrophy, then I'm not recommending waiting on that. It's already an advanced ulnar nerve, and unfortunately, the ulnar nerve doesn't do as well recovering as other nerves, particularly the radial nerve does very well with recovery of deficits. The median nerve does better, but the ulnar nerve, once you have advanced weakness and atrophy, it doesn't tend to recover as well. It can, but I tend to recommend surgery at that point.
And, when you mention slowing, just for the learners, because of the compression, when you stimulate proximal to the nerve, it slows down at the area of compression. But because the nerve is normal distally, your conduction velocity remains the same. So that's what you should be paying attention. It sometimes doesn't make sense when you're looking and why it's slowed down above versus below. But to me, it's like a traffic jam at the cinching point, and then it improves the velocity afterwards.
That's correct. Good point.
An easy number to remember also is if there's a 10-point difference in velocity, you give a little more thought to something that could be surgical here. So let's say for patients that do, you have a high suspicion for ulnar neuropathy, they undergo surgery, what type of counseling do you give them for precautions after surgery?
Sure. Well, I think there's a divide between the hand surgeons, orthopedic hand surgeons, and neurosurgeons on this question. The orthopedists like to immobilize the elbow in many cases, and neurosurgeons think more about nerve gliding. So I don't recommend a sling or a brace or a cast. I have them do some gentle range of motion right away to avoid excessive scarring in place. Of course, I will ask them not to do any heavy lifting because you need to heal the incision, but I like to put the nerve immediately into some gentle range of motion for several weeks and then see them in follow-up. And depending on whether they have hand weakness and atrophy, I will get them started in a physical or occupational therapy program after the incision's healed.
There's some dissatisfaction, I guess, from patients between carpal tunnel and ulnar nerve, like you said, because it's a motor dysfunction. With the carpal tunnel, they wake up and they feel better with the, improvement in the symptoms. How do you prep your patients in the clinic about expectations? Because, you're setting up yourself for a disaster if you're not educating your patients. So how do you counsel them as far as recovery long-term as what you're trying to achieve?
That's very important, is managing expectations. We spend a lot of time in clinic telling people what to expect and what you may not see. So you're absolutely right. With carpal tunnel, patients are so thankful. Sometimes that night they say, I got my first good night of sleep because of what you did with the carpal tunnel release. The ulnar nerve is completely different. I explain to them that the ulnar nerve just doesn't respond as well as the carpal tunnel to decompression. They may see some improvement in sensory function within the first month, but very often the sensory function can take many months and sometimes even 6 months to a year. And if it's a long time, you may never recover sensation in the ulnar distribution. The pain often does improve, but if the ulnar motor findings are advanced with a claw deformity, with a Wartenberg sign, Froment's sign, you may see improvement in strength, but the atrophy typically does not recover. Dr. Klein's series did show some patients could improve even more than 1 grade of strength, but it's not universal. In the older patients and in patients who've had motor deficits for longer periods of time, we often are dealing with preventing further deterioration, and we're happy if they stabilize and don't get worse, but we can't promise them that they'll get stronger. We, of course, will encourage them to do physical therapy, occupational hand therapy, but the strength and atrophy typically don't get all better.
So you're trying to prevent worsening muscle loss as far as the primary goal of the surgery, and anything extra, potentially can take many months to improve, but you have to put the work. And of course, if it's severe and advanced, the less likely it's going to happen, or if you have other medical conditions or comorbidities.
That's correct. Yeah.
Another question that, for the initial learner not to miss, what type of signs or symptoms you're looking for to separate a radiculopathy or thoracic outlet? So what would you, ask your resident or learners or your fellow to pay attention to if you're trying to educate them?
Sure. Very important in the differential diagnosis, because cervical radiculopathy in the lower cervical spine and the C8, T1 nerve root distributions can mimic ulnar neuropathy. Typically, with cervical spondylosis, patients will present with neck pain. Not always, but it's an important component. So we'll ask them about their symptoms. Does it start here or does it start at the elbow, which is the primary site of pain? Listen to the patient. They'll generally tell you where the problem is. For cervical spondylosis, you'll be checking for a Lermite sign or a Sperling sign for cervical stenosis or root compression. For thoracic outlet, it can also be concentrated in the hand, but again, there tends to be pain in the neck, at the base of the neck, in the shoulder area, in the inner aspect of the upper arm, whereas with ulnar entrapment at the elbow, it tends to be at the elbow and distally in the forearm and hand. Of course, with thoracic outlet, if you have deficits, then you're going to have both median and ulnar distribution deficits. So you'll see hypothenar and thenar eminence atrophy with a classic true neurogenic thoracic outlet. You don't see that with ulnar entrapment neuropathy because it's purely in the ulnar distribution. Patients with cervical spondylosis may come into your clinic with their arm over their head because it feels better that way. But if they have thoracic outlet, they hate to have their arm elevated because that exacerbates the symptoms. So that's another clue about where the source of pain may originate.
So this has been an excellent discussion on ulnar neuropathy and related conditions. In the last few minutes, we'd love to hear, just on a personal side, what led you to go into nerve surgery after your training?
Well, that's an interesting question. For me, I felt that my training in neurosurgery was excellent in cranial and spinal and vascular neurosurgery. I was very happy. I felt very confident. But I looked at my friends in orthopedic surgery, and they knew much more about peripheral nerve and especially the brachial plexus than I did. And I felt that was a deficit in my training. And unfortunately, there are many training programs still in this country that don't really have enough experience for the residents in peripheral nerve surgery. So I applied for a Congress fellowship, and I spent 6 months with David Klein and Alan Hudson at LSU and at Toronto, respectively. And I learned a lot about brachial plexus and peripheral nerve surgery throughout the body. And of course, that didn't make me an expert after 6 months, but when I arrived here at Penn, I was the only one who was really interested or experienced in peripheral nerve, so I became the guy. And so I learned a lot in those first few years. I was on the phone with Dr. Klein repeatedly, asking him for help. And that was my entry into peripheral nerve. And it's amazing when you declare some interest or some experience in peripheral nerve to your referring neurologists and general practitioners and rehab docs and trauma surgeons. They just love to see a neurosurgeon who does nerve surgery. We speak their language, and they're very happy to have a colleague in neurosurgery who does peripheral nerve work. So it's been very rewarding to train in peripheral nerve and to join a really accomplished and friendly group of neurosurgeons like you two gentlemen.
Thank you. That's excellent. And in addition to expertise in peripheral nerve, you also have expertise in open cerebrovascular. I find many times that that's common to have more than one subspecialty interest, peripheral nerve plus, let's say, spine surgery. I know Elias and I also do pediatric neurosurgery. Maybe you could talk about balancing two subspecialties in that type of model.
Yeah, that's an interesting question, somewhat controversial. I'm not sure that every chairman in the country would encourage our trainees to do two very different subspecialty areas, but I think there's still room in many practices to do more than one subspecialty. Certainly in general practice and private practice, that is a common model. Even in academic centers, I think there's room for combining. The natural one combination is, as you mentioned, doing spine and peripheral nerve together makes perfect sense. And that's why our section combines the two. We speak the same language. We're constantly dealing with that differential diagnosis and often see double crush syndromes in which there's both carpal tunnel or cubital tunnel and cervical spondylosis that you have to manage and make decisions about timing and approach to the patient with two common sites of compression. So I think for me, it was wonderful to do both open cerebrovascular and peripheral nerve. These days, obviously, cerebrovascular surgery almost requires a fellowship in endovascular surgery. So that in and of itself is a major undertaking to do both open and endovascular surgery. But for me, I was very happy doing both, and think they both contributed to my teaching of our residents. So I was happy with that.
Well, thank you so much for this wonderful, review. I certainly feel a lot better now listening to your talk here and your pearls that I, fit in quite close in my practice to yours. There was lots of pearls. I learned a lot. It was definitely a master class in ulnar nerve. Jared, any input from your end? I'm kind of jealous that you trained with Dr. Zager here, so you probably have a lot more personal experience too.
That's well, I'm very excited to have him. I think for the trainees, it's important to keep an open mind. I was lucky enough to have exposure to peripheral nerve in residency, but what Dr. Zager mentioned, that sometimes starting in practice, to be open for me, same as Dr. Zager mentioned, really not a lot of other people in the area doing this, and the practice can really grow if you're willing to take this on.
100%.
I would mention one other point for the trainees, and that is there are some excellent cadaver dissection courses that are available. There's one at LSU in New Orleans every January. It's called the Klein Legacy course that Gabriel Tender runs along with Rob Spinner from the Mayo Clinic. And I've been attending that course for years. It's an excellent exposure to experts in peripheral nerve surgery and hands-on experience. Lynn Jacques has an excellent course at UCSF, and Amgad Hanna has one at the University of Wisconsin. So, and I'm sure there are some others as well that I'm leaving out, but I would encourage anyone interested in peripheral nerve surgery to sign up for these courses. They're reasonably priced for residents, very cheap, and most programs will encourage residents to go if they have the opportunity.
All right. Well, thank you again.
Thank you.
Great to see you both. Take care.